Our next speaker is leading a project which was a recipient of a 2017 ALS Canada Clinical Management Grant. We're very pleased to have her here today. She's an occupational therapist with the Clinical Research Unit ALS Clinic at the Montreal Neurological Institute at McGill University. Please welcome Kendra Berry to speak about driving in ALS, the ALS Steering Wheel. Thanks for being here, Kendra, and the floor is yours.
Thank you very much. As Dave said, I work in the ALS clinic at the Montreal Neurological Institute in Montreal. I joined the ALS clinic in 2008. In the last 10 years working with ALS patients and their families, I've really changed not only as a person but as an OT. My OT approach has really become about finding function, finding independence, and helping patients achieve what's really important to them. My objective as an OT is always to try to empower patients with some sense of control in an illness that constantly is challenging it. In my OT experience, the three functional activities that patients seem to have the hardest time letting go of are mobility, self-feeding, and driving. And of these three, the one that I have the hardest time with is driving. It's this very delicate subject and a devastating illness, and I struggle for many reasons. First of all, as a healthcare professional, I have a professional obligation to notify my licensing authority if I believe a patient may be unsafe to drive. I have an obligation to protect the patient, but the general public as well. And when you think about that, that's actually a really big, scary responsibility. Second, there are no clear physical and functional guidelines available for determining driving safety within a clinic setting, particularly in patients with ALS. The on-road evaluation remains the gold standard, probably the best way of testing, but it has associated costs, wait times, and it has proven to be quite stressful for patients. Third, ALS is neurodegenerative. At times, it has a rapid progression. It's become easier for our team to identify when we need to get to that first on-road, but we still struggle with when do we send them for another assessment. Lastly, and probably the hardest for me, is how much importance patients place on being able to drive. For many, it represents independence. It has links to roles, identities, and even self-worth. So after one very difficult case of driving with one of our ALS patients, our team came together and we decided that we needed to find a way of addressing driving in a more consistent way with patients followed in our clinic. So this is just an overview of my presentation today. The Canadian Medical Association Guide on the Evaluation of Fitness to Drive was first published in 1974. The 9th edition was released last summer in 2017. It's a guide designed to help healthcare professionals, particularly doctors, in counseling patients about the effects of their medical condition on their fitness to drive. In the 7th edition, it recognized a legal ruling that identified the right of Canadian drivers to have their license eligibility determined on the basis of an individual functional assessment rather than exclusively on the basis of a diagnosis. This has an important impact for our patients with ALS. Patients often assume that once they're diagnosed, they have to stop driving. For this reason, there's a reluctance to notify the driving authority of the change in medical status, or even a reluctance to apply for a parking sticker. ALS patients are able to continue driving as long as their functional and medical status allows them to do so safely. According to the CMA guidelines, all doctors should be aware of their responsibility and legislated requirements in reporting patients with medical conditions that may make them unsafe to drive. The provincial licensing authorities have the final responsibility of determining driving eligibility, but a doctor's recommendation on fitness to drive is very important. In Canada, all doctors have a statutory duty to report patients they believe unfit. In 3 provinces, Quebec, Nova Scotia, and Alberta, reporting is not mandatory but rather discretionary. In all provinces and territories, doctors are protected from any legal action brought against them for reporting a patient in good faith. So the doctor's role is really to educate the patient on the impact of the illness on driving, identify any medical conditions or associated deficits that could compromise safe driving, notify the authorities if there are concerns, and if undecided, arranging consultation with a specialist, for example, an OT for a private or for an on-road evaluation. I'm now going to review some of in the CMA stated that have some pertinence to our ALS. Immediate contraindication for driving are any medications that cause drowsiness, visual changes, impaired coordination, changes in behavior, or thought processing. With all new medications, patients need to be advised not to drive until their individual response is known or side effects no longer result in impairment. In the most recent edition, the 9th edition, there was the addition of the use of medicinal marijuana with respect to driving. Any patients with a mild cognitive impairment should have on and off-road testing. Patients with moderate to severe cognitive impairments are contraindicated to driving. No test, including the mini-mental, has enough sensitivity as a single test to determine driving ability. However, abnormalities in the mini-mental, the clock, and the trail-making V should trigger further assessment. In terms of the nervous system and musculoskeletal system, any condition with a mild loss of muscle strength and control may benefit from adaptations. If the condition is progressive, it has to be followed closely and discussed when driving is no longer safe. If the physical limitations are accompanied by cognitive impairment, patient may be advised to stop driving. Any condition that has an impact on physical function can have a negative impact on driving. Safe driving requires that both hands be firmly on the steering wheel and the lower extremity to go from gas to brake with sufficient speed and force. In terms of respiratory status, it recognizes 3 levels of impairment, ranging from mild to severe. Patients with moderate to severe respiratory impairment with the use of supplemental oxygen at rest should have a test with their supplemental oxygen, the rule being that the equipment must be secured safely. Now, in Quebec, the Société Assurance Automobile du Québec is our provincial licensing authority. And according to the SAAQ, driving is a privilege and not a right. All costs associated with maintaining a license are the driver's expense. Providing false or inaccurate information could lead to the suspension or a fine. The SAAQ must be notified of any medical condition or change in medical status prior to obtaining the license, at the moment of renewal, or within 30 days of a change in health status. The SAAQ recognizes 5 healthcare professionals in declaring a patient unfit to drive. They are the doctor, the nurse, the OT, the psychologist, and the optometrist. And on the form for the inaptitude, the declaration of unfit to drive, there are 2 articles, 603, 605, stating our responsibility, but also protecting us from legal action against us. In the eyes of the SAAQ, the OT and the doctor's roles are very similar. Both have roles in educating patients on the potential impact of the illness on driving safety, identifying deficits that could impact driving safety, directing patients to the appropriate resources, and discussing possible needing to stop driving. So how to declare? As mentioned earlier, there's often a reluctance or even fear in notifying the licensing authority of a new diagnosis. The bottom line is that the driving authority needs to be notified. As a team, here at the Neuro, we share the information with our patients by informing them that it is their responsibility, and that our responsibility as healthcare professionals really only comes in notifying the authority if we believe safety is compromised. Some patients notify immediately, others wait but are aware of possible ramifications in not declaring. There are several ways to declare the diagnosis. The renewal form of the license that comes around the time of one's birthday. You can call the SAAQ, you can go to a service center, you can request an adapted parking sticker, or you can have the doctor immediately complete what we call an M28, which is a medical profile form. Patients need to know that whenever they do make the declaration, they are to expect this medical 28, the medical profile form, that will be sent from the SAAQ and needs to be completed by a physician. So having gained all this knowledge, we then decided to do a chart review. So we looked at the charts of patients followed in our clinic between April 2005 and October 2015, in which we knew that driving had been addressed. So there were 15 patients. What we learned was patients were not advised of their responsibility to notify the SAAQ. Driving was not always discussed early. Some patients were followed in the clinic for over a year before driving was ever discussed. Adaptations were underused. Only one of the 15 patients adapted their vehicle as a driver, whereas we identified a potential 10 out of 15 that may have been candidates for adaptations to prolong driving safety. And the other thing was that the triggers for us referring patients for on-roads were varied. They were inconsistent, and they didn't come from any systematic evaluations. So the next step was we performed a lit search for assessments that we could use in our clinic. One study that was interesting to us was the Maryland Pilot Older Driving Study. Its goal was to identify at-risk drivers with low-cost testing. So it used the GRIMPS, the Gross Impairment Screening, which had 5 perceptual cognitive tests and 4 physical ability tests. Of those 9 tests, 6 were identified as having predictive value for drivers at risk for crash. With statistical analysis, they were able to identify 2 types of cut points, prevention and intervention. When a patient achieved or attained an intervention cut point, this more than likely meant that the patient needed an on-road test. So what are the challenges in our clinic? The challenge in our clinic is many of our patients drive. Some are caregivers, sole drivers, parents with young children, some are still working. It's a very delicate issue. There's no good time to discuss driving. As the illness progresses, there's always new issues coming up. Driving is also often addressed by just the doctor and the OT, and in the context of our clinic, with the volume and different clinic days, it's not always addressed in a consistent manner. Patients are not consistently declaring their diagnosis, and from experience, it seems that the patients with the cognitive impairments are easier to identify for being at risk than those with the physical limitations. So what did we need? Well, we needed a systematic approach that we could apply to all the patients in our clinic. We were really looking to improve the quality of the process, but also the care provided. We wanted to be in keeping with the CMA and SAAQ guidelines. It needed to be multidisciplinary. It needed to be quick and easy to administer. And what we really needed to find was guidelines of when to refer patients for evaluations, on-road evaluations, and adaptations. So the steering wheel. The beauty and strength of our ALS clinic is really our multidisciplinary team. The concept of the steering wheel came during one of our brainstorming sessions in the conference room. The center of the steering wheel is the patient, surrounded by all of the members of our team. Our goal is really to address driving in a patient-centered manner, allowing the patient to be the decision maker, respected, informed, valued, and empowered. Our action plan for achieving this is steering the patient, so supporting the patient. I think it's absolutely imperative that patients feel supported throughout the entire process, so from the initial diagnosis to the eventual cessation of driving. We need to track violations, near misses, crashes, self-regulating driving behaviors, because these are all important red flags. Educate, also really important. We need to educate patients of the impact of ALS on driving, the responsibility that they have to their driving authority, our responsibility to the driving authority, the different options for on-road evaluations, the eventual need to stop driving with options for alternate means of transportation, and evaluate. It is a neurodegenerative illness. We need to closely monitor medical, functional, physical, cognitive difficulties, all of which could have an effect on driving safety. And lastly, if concerned or an on-road is indicated, we would refer them. So the components that we're looking at that we wanted to assess are in keeping with the complexities of the ALS diagnosis, but also by the guidelines set forth by the CMA. So our worksheets. So the evaluations that we chose target each of the identified component areas. Most evaluations are done at every visit, with the exception of the cognitive screens, which we perform at every 6 months. We retained 7 of the 9 tests from the GRIMPS battery. We developed a questionnaire. We added the review of medications. We included the MRC dyspnea scale, the ALS-FRS, the ALS-CBS, as well as grip strength. I often get questions from patients and families on the pertinence of our tests with regards to the ability to drive. The reality is we can't take all the patients to their cars, or we can't send them for repeat road tests. So these tests that we chose are really, for us, we're hoping, the next best thing. And we're really only using them as indicators for red flags, guides for us on highlighting the potential difficulties with driving. And so when you look at our worksheet, we have the assessment, the team member, and we've identified prevention and intervention cut points. So we have the medication review, we've developed a questionnaire on self-regulated behaviors, incidences of accidents, tickets. We included the FRS, the MRC dyspnea scale. We included that because that's actually a scale on the M28 provided by the SAAQ, the rapid walk. So that's being able to, with a mobility aid, walk 20 feet, 10 one way, and then turning around and coming back. Foot tap. So I just open a binder and have the patients go from each side, usually with the right foot if it's just an automatic car they're driving, clearing the binder without touching the rings. And this is really just to see if it can mimic going from gas to brake. Head and neck rotation, so that's being able to locate a blind spot. Grip strength, we're using the Jamar dynamometer, and then arm reach, just the AROM, the active range of motion of the arms. And for the cognitive screens, again, we're doing them every 6 months. You have the ALS CBS, the MVBT, we took out the visual closer section, the trail linking B, and delayed recall, which is really just giving patients 3 random words and 5 to 10 minutes later having them recall them. So we began the implementation of the ALS Steering Wheel in September 2017. So in the morning rounds before clinic, we identify any patient requiring screening. A blue folder with the worksheets is attached to their ALS file. At the end of the clinic, we tabulate all the identification of prevention and intervention cut points, and we discuss them in rounds the following week. If an on-road is required, the doctor will complete the necessary form and the OT will refer the patient. So our preliminary findings. So since September 2017, we have addressed driving with 54 patients. Of the 54, 7 stopped on their own, 3 were stopped at the recommendation of a healthcare professional, and 44 were screened using the ALS steering wheel. Of the 44 screened with the steering wheel, 29 were identified as patients requiring a on-road evaluation. So this meant that they had 2 or more prevention cut points or more than 1 intervention cut point. Of the 29 patients, 5 stopped, changed their mind, and did not proceed with the on-road evaluation. 3 patients passed away pending on-road evaluations. We still have 5 waiting for on-road evaluations, and 16 patients have had on-road evaluations. So 1 was with our driving authority, 12 were done privately, and 3 were done in a public rehab center. For the on-road evaluations, at the beginning of the project, we met with the director of one of Montreal's public rehab centers that has a driving evaluation program. It has a program that services a wide variety of medical conditions from on and off the island of Montreal. Its wait list is variable, but can average about 6 months. This wait time was pretty problematic for us. And given that the wait time with a private OT was less than 2 weeks, we decided that all patients requiring on-road evaluations would have a dual referral. They would be referred to the public rehab center with the option of having a subsidized private OT evaluation. So a private OT evaluation on-road is performed with a certified private OT and a certified driving monitor. The monitor provides the car, so it can be either standard or automatic. Before the road test, the OT performs an interview, evaluates physical and cognitive components, and does a mise en situation on the patient's car to assess the manipulation of the primary and secondary controls. And as per SAAQ requirements, the road test has to include changes in speed, familiar and non-familiar environments, non-protected left turn, and circulation in rural and non-rural areas. So our results so far. So of the 12 patients that were evaluated privately, 9 of them passed. And of the 9 patients that passed, the following were some of the recommendations. Conditions were added to their license, stating that they required an automatic transmission, power steering, or anti-lock brakes. Adaptations were identified as being beneficial, but in none of the 9 patients were they deemed necessary. 1 patient was actually told to increase the driving frequency to keep it fluid. And we were also provided with a time frame of reevaluation, which ranged from 3 to 12 months. In the private sector, in the rehab center, we've had, to our knowledge so far, 3 patients evaluated. 2 of the 3 patients passed their evaluations, and 2 of those patients are currently driving with adapted vehicles. Reflections. So in the first year of our quality improvement project, what we've seen is multidisciplinary involvement. in identifying patients that are driving, participating in the screening, providing patients with education, and helping the team come to a recommendation. I think the integration in our clinical practice has been quite easy. As an OT, I've noticed that addressing driving is much easier, and I think it's for many reasons. I think we're starting early. I think the assessment that we're using is quite holistic and complete. I think the advantage of having cut points is allowing our team to feel like we're making an educated recommendation. The fact that the multidisciplinary team is involved, I think we're promoting consistency and support for the patients. I also think the patients have really appreciated the option of having a privately funded evaluation. Another advantage that we're noticing reading the evaluations, the on-road evaluations, is that a lot of our newer cars have adaptations or are allowing our patients to compensate for some physical limitations. For example, push button ignition or parking brake, automatic locks, sensored wipers. In 2 of our patients that failed the private evaluations, both had upper extremity bilateral weakness, pretty significant, but they also had an element of fatigue and limited endurance. And I think this is something that we haven't captured in our assessment, but I really think that it's something that we need to add. In our driving questionnaire, one of the last questions is, what does driving mean to you? I was pretty surprised and amazed with the unanimity of the answers. All patients equated driving with some form of autonomy. One patient actually said that it was the only significant activity that they could perform independently. I think the magnitude of these answers just reaffirmed what we already knew. Driving is important to our patients, and I think as healthcare professionals, we really need to try to make this happen safely. So what is our hope? Well, we hope we get really smart. We hope that we can find a sustainable approach to addressing driving safety in ALS patients. We were given a grant from ALS Canada to run this quality improvement project for 2 years, so we really hope that in the next year and a recap of the 2 years, we do find something that is sustainable. We hope to identify tests that are useful in predicting the results of road tests. We hope that we show the necessity of reducing wait times for our patients in the public rehab centers. We would love to see the increased use of adaptations that have the potential of prolonging driving safety. But our biggest hope is to promote and prolong driving safety in our ALS patients. Our hope is to give patients a sense of function, independence, and control. So a big thank you to ALS Canada for supporting our initiative, and of course the ALS team here at the Montreal Neurological Institute. Thank you.
Thank you very much, Kendra. We really appreciate that. That's an amazing study, and we're very proud to be supporting it. We're pretty tight for time, but I have really quickly one question, and that is, can you envision that, there are so many things that people with ALS, want to maintain independence, and I'm sure you see so many of them and things that they're doing to try to maintain that independence. Can you envision that more of these studies are necessary that would be able to monitor and find ways to evaluate other modes of independence for individuals? Besides just driving, are there other things that you think these types of studies might be valuable for?
Yes, I think absolutely, and I don't know if I understood the question correctly, but I think there are studies, for example, the Neater feeder, which is an automatic feeder that is not necessarily accessible to patients. I'm hopeful that one day we will see it available, funded, because again, I think it gives patients the independence to complete something that is important to them. And I think it allows us to really focus on what's quality of life for these patients with a difficult diagnosis. I don't know if that makes sense.
No, it does, absolutely. I was just thinking about how, the work that you're putting into do a more formal evaluation of things that are important to maintaining independence and quality of life can be adapted potentially to other things. And yeah, I think certainly the Neater feeder is a great example.
Absolutely, and absolutely, yes.
Well, thank you very much. We really appreciate it. We look forward to seeing how the study keeps going, and hope you have a wonderful rest of the day.
Thank you so much.
Thank you.